Good afternoon. Welcome to the secure webinar number 5, Strengthening Health System Resilience Against Climate Change in Indonesia. And we have distinguished speakers and panelists for this afternoon's webinar. To start with, let us welcome the Principal Health Specialist uh, in charge of the Secure Project Officer of the Secure TA, to provide us an overview of the secure webinar series and to provide us the welcome remarks. Dr. Eduardo Dodo Banson.
Okay, thank you, Randy, and welcome everyone. So it's really nice to have for people to still come here during the December last month of the year. But I think it's quite important. We'll be talking something really cool. We'll be talking about something which we in the security A always wants to look into, which is health and climate change. So I'll step back a bit. So Security A is what we call a technical assistance project of the Asian Development Bank. It was originally designed. It was designed to support COVID-19 vaccination efforts of countries in Southeast Asia and other health security measures that the countries will be adopting. In the course of the implementation, of course, we realized that there's really importance for us to see how countries are adapting or mitigating the impact of climate change, given its relationship, how, in a sense, climate change really magnify health security risks. So we have been part of what we do in Secure is not just go into countries and assess what's happening, but really facilitate sharing of experiences. And the webinar is one of the tools that we use for the sharing of experiences. So this is the 5th of the webinar. And our plan, of course, is the webinar will not end today with the webinar because of we're now in a digital world. We plan to post this in the web. We plan to share this webinar. So our speakers, Dr. Krum, Dr. Ferdinand, Dr. Budi, Mon. So we will be sharing what you're going to talk about, discuss about. The questions will be asked into the web, and we would expect that we will, of course, multiply those who will be listening to it. So as said, this is we will be focusing on health and climate change. We will be looking first into Indonesia. We plan to look into other countries in Southeast Asia in the coming months next year. So Randy, give the floor to our esteemed speakers. So I think so we'll have a very enriching discussions to follow. Thank you.
Thank you, Dodo. The key presentation is actually a study on climate change adaptation on health sector in Indonesia, and this study was led by Dr. Ferdinand, who's the Deputy Director for Administration of Southeast Asia Regional Center for Tropical Biology, and together with 2 others who later on I will be introducing. Dr. Ferdinand?
Yes, I am.
And we have also Mr. Ikram Mustafa, who is the Director of Research and Survey.
Hello, sir.
Hi. And then Mr. Rico Farsika Adi, SCC, P Area Environment and Technology. So let's start with Dr. Ferdinand. Your presentation, please.
Okay. I will share my screen here. If I'm not mistaken, Mr. Randolph, I have like 20 minutes here for the presentation.
Yep.
Okay. Sorry, I have some issues with my voice. Yeah. Oh, it's just thank you right away. Sorry. Okay. So climate change adaptation on health sector in Indonesia. So actually this is much more review study for the ADB. So I'm as a project leader. And then there is my team, Mas Rico, Faris Kadi, Mas Ikram, and also the 2 assistants, Miss Safara Risa and Miss Revia. So it's gender balance already, yeah, because there are women scientists involved here. So my presentation is divided into 6 parts: the background, profile of climate change and health in Indonesia, legal basis. Because I think if you want to discuss with the government, we have to understand what kind of legal situation in the country. health risks in Indonesia, necessary activities for climate change action plan. So even though in health risk, maybe we're gonna discuss quite specific with regards to Indonesian current situation, as they are doing based on the health disease, but we want to see based on the health risk perspective and way forward strategies and recommendation. This is the background. Indonesia is considered one of the regions severely affected by the impact of climate change. The new climate regime might raise the disease incident rate and increase disease infection and transmission. I'm pretty sure Professor Budi, who are also one of the panelists, will can have much more elaboration on this one. Will increase disease infection and intensity. So Indonesia also already measured, Ministry of Environment and Forestry, changes in number of climate-related disease will affect health sector up to 1.88% or almost 21.6 billion US dollar, which is quite huge. The health issues in terms of climate change is also already one of the priority in Indonesia Development Plan. Initiative on developing health national action plan is already done by the Ministry of Health and is supported by the WHO. In 2020-2021, the Ministry of Health also developed guidance for a health climate resilient village. They call it Desa Desi. So in simply, actually, the Indonesian government is quite, what I say, active in combating climate change on the health sector, starting from the policy tools and up to the action at the village level. So this is the profile of climate change and health in Indonesia. So the team is try to picture what kind of issues across the country. If you look at on the left-hand side, the dengue, malaria, diarrhea, and pneumonia. So this is what already did by Indonesian scientists in many reports that we try to map it. Increased rainfall and increased temperature, they already have some correlation with this number of diseases, and also the location, as you can see, starting from Sumatra, Java, Kalimantan, Sulawesi, up to Papua. So almost the situation is need a lot of attention as the disease incident occur across the country. The potential losses that I already told before, the health risk from the threat of climate change, particularly is vector-borne disease, waterborne disease, foodborne disease, airborne disease, and non-communicable disease, disaster, and nutritional problem. Climate change affect the distribution pattern of disease factor and increase the incidence. So actually the main issues is the distribution, the dispersion of the disease under climate change as the temperature is rising and the rainfall changing is evidence in everywhere of the country. So we might have a new situation that requires us attention, what kind of strategy, proper action that we need to implement. So the legal basis of climate change and adaptation sector in Indonesia, we started by looking at what kind of law, presidential regulation, up to ministerial level regulation. This is what we map in the left-hand side. So climate change adaptation for the health sector is directed to reduce current and future risks following the mandate of Law number 16/2016 concerning the ratification of Paris Agreement. So as mandated by Paris Agreement, Indonesian government already put health as one of priority sector in combating or in addressing the climate change impact. So this is the regulation. And then we also try to link the NDC adaptation strategy. What we mean here is what our response to climate change with the new initiative on health sector in Indonesia. There are 6 pillars of health transformation as you can see on the right-hand side, transformation of primary services, transformation of secondary services, transformation of the healthcare and security system, transformation of healthcare financing, transformation of healthcare resources, and transformation of healthcare technology. So we look at the interlink between the directive of Presidential Regulation number 98 2021, which is talking about climate change impact and adaptation as part of the presidential regulation. You see there are 5 targets there: food security, water, energy, and health security ecosystem. So we interlink them with the NDC adaptation roadmap strategy because Indonesian government already submitted to UNFCCC. They call it adaptation communication. And then what is the interlink here? We have we put some number there. Participation of various stakeholder, most likely is participation stakeholder, financing mechanism, capacity building, and application of advanced health technology to promote efficiency of the health system. So the connection of the NDC strategies on adaptation with the 6 pillar of health transformation can help formulate interlinked action that encourage climate health resilience in Indonesia. So the target is how we can improve climate health resilience in Indonesia. I'm very sorry for this complex information, but I think the essence is how we can see the supporting evidence and the supporting policies are already in place. So we need to implement all the strategies and recommended action to get the benefit from addressing climate change impact in Indonesia. So this is, for example, some tools that already developed by the Indonesian government. Health Risk Information Indonesia, they call it APIC portal. Is you can see, you can go to website apiccamcas.id. So this website or this portal actually provide indicative information about the potential about the risk of climate change to a number of diseases. So many studies now are still focused on dengue and malaria. Existing tools on climate health risk, there is APIC-CAMCAS, this is what I says, and at a Ministry of Environment and Forestry, even though it's not directly linkage, but they already have the vulnerability information in the system. They call it SIDIC, System Data and Index Kerentanan. And then the health information services at the Pusat Krisis, they're also there. And the last one is about disaster, which is published at the risk assessment portal INARIS by BNPB. So our study team tried to map all the existing situation related to health risk in Indonesia. So for risk assessment related with the pillar of health transformation, we also look at the availability and compatibility of health data information is still challenging for conducting health assessment in Indonesia. The Ministry of Health Studies in 2022 finds the main issues on data information readiness is because of these 3 issues. So this is the essence of the finding. Differences in format and period of recording for specific type of disease. Availability of data only at the provincial level or in certain areas. So the continuity of the data supply is some issues. Unpublished and limited access to data. So this is why this can happen, is triggered by differences in priorities refer to the disease incidence, because our understanding of the disease, etc., is also different. Disparities in health workers' understanding of data and information for specific disease. So and there is no standard operating procedure for data recording and sharing mechanism. So our team is really focusing on actually look at the data readiness in this regard to support the assessment of climate change on health. We also map some data set there, and if you can see, there is a note number in our figures is talking about the 6 pillar of digital health transformation. So if you see, for example, community welfare is related with the pillar of number 1 in digital in the 6th pillar of digital health transformation. And it also related with the Bloom theory, genetic, health service, lifestyle, and environment. Like I said in the beginning, actually our intention is to look at health risk system, so not specific diseases. The problem is the available data set in Indonesia is much more at specific diseases. So we try to look at the combination of those. This is activities when we talk about necessary activities for climate change action plan, current situation on action program. So we map in this figure program and key stakeholder that we think is related with the climate and health. And you also can see some logo there. So the logo says us about who is the ministries or agencies that is organized the program. There are a number, there are 38 program related with the climate change action plan. So this is a good information how we map the modalities that is available and what kind of issues there, and then we can formulate what we can do to much improve the program. The key stakeholder here, you can see the logos, and we put the name of them. The legend also we provided to read this kind of figures. When the first one is the program name, number there talking about the NDC target, and then the color climate is talking about climate related. If with the health, if you see with the blue color is health related, and the parties who are involved. And there are also 8 strategy on the NDC roadmap of adaptation aspect. So in sum, these figures explain us about if we want to have some kind of intervention. So we already know there is already available program or existing program that maybe we can link on with our new initiative. So this is the activities, the continuation, because we want to formulate what kind of action that we still needed. We look at the 5-year climate change adaptation work plan, tangible output. So tangible output associated with the 6 health transformation, guidance, strengthening the APIC website, strengthening the surveillance system, and climate resilience design. This is government policy and program that is from the previous slide that we can link with, let's say, the 3 objectives: policy and governance, how we can improve policy and governance; vulnerability and risk assessment, how we can improve vulnerability and risk assessment; and the last one, how we improve climate change adaptation. So this work plan is still ongoing and may require further effort, as some work plan has not yet been implemented. The tangible output can be associated, as we did here, with strengthen the health sector resilience, including after the COVID-19, and might relate with current climate change and health government. So what we should do then? So we look at the potential cooperation. The potential cooperation, not only across sector that we already presented before, in here also the potential source of fund. There are a number of source of fund, a domestic and foreign source that you can look at in this figure. However, Indonesia has many other urgent needs or development priorities as developing countries. So how to link and match this kind of source of fund with the Indonesian needs for strengthening the health sectors in regards to climate change. Climate change budget is still not sufficient, not much funding as well as of now to reduce specific impact on the health sector. So Indonesia still need more both financing and technical assistance to implement climate change action. So this is the last one, way forward strategies and recommendation that we develop based on the gaps. Yeah. So we map the recommendation here based on what we sees as the gap. So the gap is in here, you can see in the middle of the figures. We look at from program category that we categorize based on policy document, local action, tools and development, capacity building, literacy, and funding mechanism. And we interlink with the 6 digital transformation on health sector because the ministry have this as a core policies now. This is the gaps: research in health sector, understanding contributing factor, data readiness, ensure data collection, technical guidance, and so on, up to database system mechanism and knowledge sharing for local action, develop monitoring and evaluation mechanism. So as we said before, we are not specifically look at its diseases, but we look at from the health risk requirement regarding climate change. That actually, this is the program we map again in here, the 36 program, and we put the number. So we link all the information to find out, so we can have like integrated recommendation. So this is the recommendation. Gap are the basis for designing specific recommendation for climate change health intervention in Indonesia. This is potential activities. Indeed, we need to discuss about this one. ADB and other colleague here, maybe you can have some comment on this one. For the policy document, related document, I mean, actually it's not document, yeah, for policy related activities, climate change policies, Indonesia related to health still focus on environmental health. So need to develop towards human well-being. Need to distinguish differences in economic loss and benefit for urban, coastal, age group, gender to facilitate more targeted policy planning. So this is what we think we can provide some intervention to the policies, yeah. Enforce policy instrument and strategies on emergency preparedness, disaster management, including development of national emergency nutrition toolkit. Increasing institutional capacity in health sector. I think this is demanding now in dealing with outbreaks of infectious and non-communicable disease caused by climate change. After the COVID-19 situation, I think this one is required now. Development of standard operating procedure for recording and documenting disease data related to climate change impact. So we can work with much more stakeholder, yeah. So this is really required effort from many entities. For local action, strengthen national and subnational working group on integrated and community-based health movement. Supporting health climate village, they already have the initiative program, the Ministry of Health, they call it Desa Sehat Iklim. So how this initiative can be supported through pilot project, providing implementation need, such as technical guidance, technical assistance for coordination, as well as other operational needs. Tools and development, I think this is also critical, because if we look at using the manuals, etc., that is not easy to use, we need tools to help on this regard. Ensure data collection on social economic, including parameters of vulnerable group, strengthen the new paradigm of digital health transformation with a clear legal basis policy. In here, research is needed to examine whether existing policies and regulation can accommodate all health transformation initiatives. So there are 6 initiatives there, 6 programs. Improve learning tools. Yeah, I think learning tool is still important on climate change adaptation and mitigation for health sector, because as climate resilient pathway already adopted globally, so we have to look at adaptation and mitigation as the same coin. Stakeholder forum for sharing knowledge maybe can be much improved using web-based or digital platform service. Improve web portal on climate health, named EPIC. So this is all the modalities that already did by Ministry of Health. Maybe we can have, we can improve them all. Develop surveillance and early warning system. So it's not only web-based, but real-time monitoring. Develop database system. For capacity building, indeed, many capacity building is still needed. Apply, acknowledge humanitarian aid standard. You can look at in this slide, public health emergency, environmental and climate-driven industry. I think our colleague from public health can help a lot in this regard. Build collective understanding of community health and climate risk profiling, train the public to be able to access and utilize various information platform. For example, that is already developed by Ministry of Health or other colleague. Strengthen current implementation of climate-sensitive policies and program. There are many climate-related health program that we can strengthen. So we are not reinventing the same wheel. The last two, literacy and knowledge management, we can conduct formative research with the view providing scientific-based evidence. I think now this 5A, there are a number of research already going on in Indonesia that can help us to much improve our understanding about climate change and health. Distinguish climate and non-climate. This is very important, how we can understand the different contribution of climate and non-climate contributing factors to favorability of health sector. Identify data readiness for indicator of climate health assessment. We already made some initiative on this one, but then how we map and how ready this one. Develop knowledge and management information. And the last one, deploy community-based health climate information system using crowdsourced technology, which allow communities to meaningfully participate in anticipatory action and risk mitigation measure. The last one is actually to encourage public participation. Yeah? So we need some initiative or innovative system how the public can be recognized, they can be appreciated for their contribution. Funding mechanism, integrate climate resilient health in policy development of budget and expenditure. I think we need to discuss about this one with Ministry of Finance, because I know Ministry of Finance, they have specific institution now, a Badan Kebijakan Fiskal, the Fiscal Policy Department that can help us on this regard. Allocate substantial funding for climate change action on health. Develop guidance to include climate action. So how we can have the guidance, hopefully is automatic guidance that people can just click and then they will know what they have to do. It's not like reading the guidance line by line or page by page, which may be required much more time to understand. Develop tools to measure the effective and efficiency of funding allocation. I think this is very important because in every country, the funding allocation is very tight. So we need really to help them know, for example, like cost benefit analysis or cost efficiency analysis or related, that it can be easy and specifically designed for climate change and health. Build capacity, the last one, on of national and subnational stakeholder in assessing different sources of fundings. We already mapped, there are a number of funding from internationals and also nationals, how this can be used by the subnational stakeholders. So they need to understand how to access, what kind of requirement they need, etc., etc. So hopefully this can trigger the discussion for today's meeting. Thank you very much.
Terima kasih, Dr. Ferdinand. Thank you for the very interesting presentation on climate change and health. Now we have two distinguished reactors. The first one is the director of the Research Center for Climate Change in the University of Indonesia. He's also the member, among others, of the International Association of Doctors for the Environment, International Epidemiology Association, International Society for Environmental Epidemiology, and the Board of Directors for the Pacific Basin Consortium for Environment and Health. Ladies and gentlemen, Professor Dr. Budi Haryanto. Dr. Budi.
Good afternoon, Pak Budi.
Thank you.
He's
Hello,
my teacher ini. He's my teacher, Pak Randolph. Please, Dr. Budi.
Okay, thank you. Let me share the screen first. Okay. All right. First of all, I'd like to thanks to the IDB that inviting me in this very honored occasions. And then secondly, I'd like to congratulate to my bro, my bro. Okay, Bang Ferdinand ya. I believe that he works very hard to what they call it, to generate this report. And thirdly, I'd like to share comment to the report, but more likely in the point of view research on climate change and health. Okay, let me start with the outline here. Okay, I'd like to, I have some notes for chapter of Indonesian profile of climate change and health, future predictions, and also several notes for vulnerability assessment for disease, and how these two notes implicate to health resilience or adaptation strategy and program development. So based on my background, I only comment for these two and the implications. All right, let's start with the profile of climate change and health in Indonesia, future prediction that already been presented by Bang Ferdinand, yeah. And I'd like to say here that this is a basic, yeah, this chapter or this part is basic and very important, but unfortunately, lack of the reliable data and evidences. Okay, first, the evidence of CC and health should be based on long-term time series data. It's still under question whether the data already been, the information already been presented, already using long-term time series data or not, since Ferdinand also mentioned that the readiness of data as well as the data provided is still still not complete for analysis. And secondly, disease outcome selective should be derived from analysis using epidemiology analog and ecologic design. Okay. Has already been followed by most of environmental epidemiologists and those who work on public health. If we are talking about CC related to climate change related to the health, then mostly we use environmental epidemiology methods. Here is the analog design. This actually showing the trend of climate change components, yeah, like temperature, precipitation, and what's it? Wind direction and wind speed, yeah, and so on. And how to connect it with the every single disease outcome. Every single disease outcome. Why? Because every single disease has its own natural pathway of disease, and this is actually unique. Yeah, if we are talking about dengue, hemorrhagic fever, yeah, dengue virus, it's spread by mosquito of Aedes, and the spread is occur during the day, early morning, and as well as before night, yeah, and late afternoon. Yeah. Well, if we look at like malaria, it's also spreading by mosquito, but different mosquito. Yeah, it will occur at night, yeah, at the evening after 9 p.m. so on. So this very unique, even though the same mosquito that bringing the virus or the parasite. Okay, and that's all for analog design, and I'd like to share you later on. And secondly, is ecological design by time. Yeah, this is actually the purpose is for analyzing the association between the climate change components and every single disease outcome. That again, it means that one by one of the disease, since it has the unique characteristic, of course, by using the time series data. So I believe that all of us aware that if we are talking about climate change, then we are talking about the time series data for more than 2 or 3 decades, yeah, even until 100 years. And after that, they calculating prediction for the future trend. Okay, this is actually the original of methods that provided by the founder of climate change and health studies, yeah, the late Professor Anthony McMichael from Australian National University, and now a lot of his successor, yeah, like Christy AB and Washington University, as well as the Sari Kovac, yeah, from London School of Tropical Hygiene and Public Health. Yeah. So it's mentioned that there are 2 design study that appropriate to be used for studying the association between climate change and disease. Yeah. Then we are talking about analog studies. This is actually mostly overlay the trend of disease under study and the component of climates. And then the secondly is predictive model. So that is using empirical statistic model. Yeah, this is actually we call it as ecologic design by time. So this is using the statistic to analyze the association between the climate change climate components, yeah, and the to every single of this. And of course, the 1, 2, 3. This is the second of the predictive model, yeah. This is process-based or biological model. This is actually how to look at more thoroughly concerning the bionomic factor, and as in laboratory as well as in the environment. Okay, this actually the example what I okay, sorry. The example for, let me find my pen. This is the example of the analog studies. Yeah, we can see here that in the in block here is actually the incident of dengue fever. Yeah, this one. It's the incident of dengue fever per 100,000 population, yeah, and it is overlaid to the district or city that already been affected. We can see here in this picture that the incident of dengue fever is increasing since the first time founded in 1968, yeah, until 2016. Then we can see here there are a decreasing trend in now 2017 and to 2018, but again increasing in 2019, 2020. It's been reported that about 70% of district city already been affected by the spread of COVID-19. Sorry, dengue fever. Which means that it is difficult to find a safe place for not being contacted or risk to have the dengue fever. And this actually this exactly the overlay of, yeah, and it's actually what we call it as analog studies. If we use the component of climate, then of course the line of something like this, yeah, it's quite the same with the trend of city and district. Yeah, probably if we look at, if we for example look at the temperature, then probably it's like this, yeah, the temperature is increasing but it's not very sharply. So this will tell us about how the trend of single of disease in this example is dengue hemorrhagic fever with the there are association with the increasing of temperature or not. This another study. And if we are talking about dengue fever transmission, then this already been published. Climate change is also affected to the chains of the mosquito. In this example, is the Aedes mosquito that bringing the virus of dengue. And this mosquito breeding cycle is shortened right now, yeah, and since about 1 decade ago. It's been shortened of life cycle. Previously, it's mentioned that from egg to adult mosquito, it needs about 12 days. But since 10 to 15 years ago, it's found that right now the life cycle only needs 7 to 9 days. And because of the shorten of breeding cycle of the mosquito, then right now the size of mosquito is smaller than before. Yeah. And the virus in the mosquito is also shortened because the life of the mosquito, the mosquito is smaller, yeah, and because of the smaller, then length of length of flying, yeah, length of flying of the mosquito is also farther because the wind velocity also bring this mosquito farther. For example, previously the mosquito length of flying is about 70 meters, but since 10 to 15 years ago, it's already been found about 140 meters radius. What it means, it's very important to for the control of mosquito, the adult mosquito, yeah. Because previously, because of the length of flying is only 70 meters, then the radius for fogging, yeah, poking action to kill the adult mosquito, usually only 100-meter radius. But since then, when increasing of length of flying, then of course right now it's needed to do fogging to kill the adult mosquito further, yeah, for example, 200-meter radius. All right, okay, and the frequency of the mosquito to bite people is also more often, because previously every 5 days they will bite another people, yeah, and spreading the virus from his body. But right now, only 3 days, and they need another blood for feeding. So if we are counting for the life of this mosquito is about 45 days. So it will be about 9 times during the mosquito life will bite other people. That's why that more this actually more efficient transmission of dengue virus to human. Okay, this is that's actually telling about the analog data. This is also analog data that also indicate to the the strategy or program that being developed to for the action of resilience or adaptation in health. We can see here that this the trend of malaria from Ministry of Health, yeah, data. We can see that from 2010 to 2014, 2015, yes, it decreased. But when we look at 2015 to 2020, as well as this is 2021, yeah, it is difficult to believe that the Ministry of Health mentioning the successful of the program of elimination, malaria elimination. It is hard to believe, yeah, you can see here. So, and then the Ministry of Health having a target for malaria elimination in 2030. So this actually the information that we have to look at more thoroughly, yeah, about the cases. It's not only to make better report, something like that. All right, this is another example for prediction. We already did the research with the Bapenas and WRI. We found that in Bandung, Palembang, and Jakarta, this is actually concerning to the air pollution and diseases. You can see here PM2.5 and SO2 with pneumonia, with bronchopneumonia, with asthma, with acute respiratory infection, yeah. And we found that the regression, that's association, and then also the gradation and equation. And of course, we would like to do the prediction. We have to use this analysis of the data. And this is the example of the predictions. And for me, it is very important to put also in the profile of Indonesia in chapter 2, yeah, in the point 2 of the report. This is the example of for Jakarta. You can see that an increasing per 10 microgram per cubic meter of PM2.5 was associated with the increase about 6% of pneumonia cases. For SO2, increasing 10 microgram per cubic meter, associated with about 7% of pneumonia cases, and as well as for PM10, yeah, increasing in 10 microgram per cubic meter, associated with about 1.5 acute respiratory infection cases. So if we have this kind of result, then it will be strengthen the profile of climate change and health in Indonesia, especially. And this is from WHO since 2000, and the year 2000, that most diseases have multiple causes, and socioeconomic factors are particularly important as they determine adverse environmental exposure, degree, diversity, and type of disease, acute and chronic, infectious and non-infectious, physical injury, and mental health disorder, the many uncertainties regarding the biological and physical processes by which climate or weather affect health, the long-term nature of the change involved, and most epidemiological studies have been done on a local basis, and therefore application on a wider scale is difficult, but still possible. Okay, and then the second note, this is about the vulnerability of climate change to the health adaptation. So the main of my note is that this is actually the general vulnerability versus specific natural pathway of every single disease. What I mean here is that if for health effect to health effect caused by the climate change, it is different, because if we're talking about health, then we are talking about the disease. And every single disease, as I mentioned before, that having a specific natural pathway of disease, specific of like if it is caused by factor, specific of dynamic of the factor. So this is a unique, and we should be one by one analyze the association between climate change and the disease. So it's mean that we are not almost not possible to generalize the result. If we are talking about all of diseases with climate change and the changing of all diseases with climate change, then the bias is very, very big. So the calculating vulnerability by place, comparing to several places of climate change for every single disease outcome. Like the step one is generating appropriate variable. Yeah. Of course, because of every single disease has a unique of characterization. So the first, before doing the equation of vulnerable, we have to generate the variable, the appropriate variable related to the disease in the exposure, in the sensitivity variable, as well as in the adapting capacity. Usually for adapting capacity for several diseases is quite the same. And secondly, defining scoring for each variable involved, and then calculating vulnerability coping range index. And lastly, mapping the area under study based on the finding of vulnerability index calculation. And here is, we already familiar with this, I believe. Yeah, what is the exposure, what is the sensitivity, and what is adaptation. And I'd like to show you. This is actually what we already developed in 2013 when we study the association between the climate change and dengue fever with malaria in 20 district and city in 5 provinces. This, it was the collaboration between we are in the Research Center for Climate Change Universitas Indonesia and the Ministry of Health by supporting ICCTF funding. And these were 2 year study. The first year is for studying, for research conducting by UI, and then the second year is socialization and application that conducting by Ministry of Health. And we developed this with several tests that the exposure for the exposure variable for dengue fever is actually involving land use, yeah, like settlement, offices, business, school, and so on. Because most of the disease spreading in this location, and we also putting the population density in the exposure, and of course the climate component of the exposure. And this is more specific, yeah, in the sensitivity is very, very unique, as I mentioned, for every single disease. Because of this Aedes mosquito as the vehicle of the virus. So the breeding places and resting area is very important to be seen. And pupa and adult density is also very important. Incident of dengue fever by sex, its occupation, education, and so on. And specific population mobility. Yeah, like during the bite time of the Aedes mosquito in the early morning or late of afternoon, who are the people, who are the specific people that are staying at home or staying at school. So this is very important. And in the adaptive capacity, I think we already familiar, yeah, about availability of health services, treatment management and skill provider, and so on. So this is very different with the variable for exposure sensitivity, especially in the malaria. And we are talking about diarrhea, it's also different. And if we are talking about respiratory tract diseases, this is also very different for the exposure and sensitivity. This answering the because of the uniqueness of natural pathway of disease for every single disease related to climate change. And I believe that we are already familiar with this coping range index, yeah, on the vulnerability. And by scoring and calculating the clear component of vulnerability, then we found like this. Yeah. This is in Jakarta and Banten in 2011 and 2012. We found that in where is it? Tangerang, yeah, Tangerang district, copying CRI, copying range index is still green, yeah, is safe, but in Kota Tangerang, Jakarta Utara, North Jakarta, is Central Jakarta is quite high. And this number 3, level 3, I think. Let me see. Oh, the index is level 4. And We can see in 2012, it is increasing this level 4 and level 5 for the CRI. And what happened with East Java, you can see here, 2011 and 2012, yeah, is quite same. This is actually the mapping, it's already mentioned as well. And this is, I think, is more important of the implication to the program, the development. Yeah, we can see here that all of the cases by address, we put address of the patient of the dengue fever patient from medical records. Yeah, if we are not find the medical record by address of dengue cases in city or district health office, then we invite the puskesmas, the surveillance from puskesmas, to bring their medical record, and then we collect it in the cities, in the district. Then we found here putting the patient address by coordinate. Yeah, and what we can see here that actually the occurrence of dengue, it is usually on the group it over here. Yes, group it over here, and some outside of this. Well, I said this is we put also buffering 12 meters, yeah, radius from the home, the address of the exit. We can see here that actually the cases is just running here, and for the program development, we can see here that if we do a more focus on this area and this area by revitalizing or by evaluating and revitalizing of the program already been done, then we may reduce the cases more than half. We focus on here and we focus on here. Rather than, I think it's will be better because sometimes for dengue cases, the program is, the money is given to equally to all of the district over here. This district kecamatan, sub district. Yeah. So if the program will meet our it's important to I mean if they are 2 days mapping and found this location of the very important, then of course the focus of the program will be very beneficial to reduce the cases. And this is the last one that how is the implication of those finding from the research that identifying the existing counter program of every single diseases, yeah, and analyzing business as usual program with the trend of disease of time. This is important because as we already know that the effect of climate change to health or to disease, actually, if we can see the gap, yeah, if we can see the gap, I mean, how is the trend during several years or during 20 years, for example, and why the increasing of and if we found the increasing very sharply of the diseases, then the gap is actually affecting by climate. So we have to find the trend of usual business of usual diseases and the game. And of course, by this finding, we can develop the program ideas. For example, how to evaluate the program. Can we say that it is successful or not? And how to revitalizing if we found that we still have to mention. And as the conclusion, I'd like to say here that profile of GC and health in Indonesia should be based on studies or evidences. Which is very important because this is very beginning of the profile to do next step here, how to solve the problem by generating the strategies, the policy as well. And secondly, vulnerability assessment of health caused by CC should be generated one by one the disease. And research design appropriate for CC and health are analog ecological time frames still in vulnerable bad place for every disease and mapping for potential risk factor. And of course, I suggest that by involving environmental epidemiologists and public health background by training or experience will be beneficial for better and less scientific approach. I think that's all that I like that I share. Thank you very much.
Thank you so much, Dr. Budi, for the comprehensive reaction and presentation. And now we go to the next reactor. He's the Executive Director of the Healthcare Without Harm in Southeast Asia. He's also a member of the World Federation of Public Health Association and has worked with several countries such as the Philippines, Singapore, Taiwan, Thailand, and Indonesia. May I proudly present Mr. Mon San Pascual. Mon?
Thank you so much. Again, thank you to ADB for this opportunity, proceeding and continuing the series of webinars under Secure. I think this is my second or third time that I'll be participating. But I'm honored and I congratulate this early, the team of Dr. Ferdinand. I think you're producing here a breakthrough literature and hopefully a basis of action on real work on climate and health adaptation, particularly in a very important country where healthcare without harm is also focusing on. Among the Southeast Asian countries, we know how influential and how huge the impact of Indonesia to the rest of the Southeast Asia region. And I'm really happy to note the presentation earlier. And of course, I also listened to your presentation, Professor Budi Payanto. But as a reactor, I'll be first. Let me share my. I don't know if I already share my screen. Do I have my presentation right in front of everyone?
Not yet.
Yep.
Chat.
Yep.
Wait. It's there. Okay. Well, I prepared a set of slides on what we do in the region as healthcare without harm. Being the executive director for 6 years now, we're doing a lot, and I can say that 70% of our work is on climate and health across hospitals, healthcare systems, and healthcare professionals in the ASEAN region, plus the countries of Taiwan and Korea. But before dwelling on that, if you don't mind, because the first presentation is really interesting, if I can just send out reactions, questions, and perhaps certain recommendations as well, because Indonesia is our country of interest. We have partners there, we have projects also on climate and health. So let me start on slide 3, for example. There is that mention of the impact on the expenses on the health sector would be up to 1.86% or around $21.6 billion. I think if we can elaborate a bit on this, on how this came about, but much more to use this figure once justified, what therefore would be saved if we adopt measures as early as now, both on resilience and mitigation and building adaptive healthcare system in Indonesia, then how much cost will be reduced from the anticipated health impact or health climate impact on health in Indonesia. But I'm happy to note that there is such a figure cited, whereas in other countries in our region we haven't seen this yet. Secondly, the Health National Action Plan has rolled out in many ASEAN countries just before the pandemic. And for some reason, of course, just like everything else, the COVID-19 pandemic halted many development and health initiatives, even those focusing on climate. And yet, I wonder, because it says here that it has not been fully implemented yet in the Indonesia, how far has it been implemented? What sort of, is it a localized initiative? Is it a pilot? Because we are interested to see how, from a national adaptation plan mandated across countries in our region, it is translated into health adaptation plan. Not too many countries have done that again. If Indonesia can showcase certain, even a small part of that larger health national adaptation plan and showcase successes, it will yield influence across other countries in our own in the Southeast Asia itself. And another well, there was a mention earlier that the study on health impact of climate is usually focused on the usual diarrhea, pneumonia, dengue, malaria. And again, this is fully justified, and that can be understood from the perspective, for example, of epidemiology of certain diseases. But more and more, there are other studies citing that mental health is a real concern created due to the trauma that is caused by climate events, displacement of people in itself will yield a different health impact to communities and to full segments of the society as well. So what I'm saying perhaps is that we need to broaden when we profile climate change and health and how climate change impact health, that we should be able to broaden the perspective from a disease kind of focus to a more broader sectoral and even genderized kind of health impact. And there is citation already that mental health as an impact of climate as an impact of climate change is affecting more women. Is this also true in the Southeast Asia? There are other questions, and apologies that I'm focusing on this, but this is really an interesting work that many of us in other countries can learn from. When you mentioned the risk assessment and the sixth pillar of health transformation on slide 7, the model seemed to be very catchy and makes sense. How far again is this being carried out at the local level even? Especially building the adaptive capacity based on the sensitivity set up here, whether the community welfare, historical disease, And how are they really linked together to produce adaptation plan that includes healthcare? The theory that healthcare without harm holds is that the healthcare sector itself can be considered as the anchor of community resilience in a climate threatened society. Meaning, uh, if the healthcare as a sector, as an institution, as a facility, as a profession can showcase various dimensions of resilience in a certain community, such influence can yield even a greater resilient villages or sectors within that community. And seemingly, that model you showed in the slide suggests that. And so I wish we can show results as well. On the preceding, uh, I think last three slides, way forward on strategies and recommendations. Uh, I don't know to whom this is being addressed, and is there a specific set of audience in Indonesia where this will be offered and this will be acted upon, hopefully. Uh, but certainly, a healthcare without harm would want to be part of the policy actions that has been recommended here. And even our presence is more in the West Java set of hospitals. So if there are local actions that are also where we can match our resources, initiatives, and partners, let's work together on any of these way forward strategies. Now, our particular interest, because we're also focusing on tools and development and capacity building. We have tools on resilience training. We have tools on waste management assessment, including uh, measuring the carbon emission coming off from the waste produced by hospitals. We have tools on energy, again, on carbon footprinting, energy use inside the hospitals. So if there are things that we can work on together, I'll be glad to work out some kind of a discussion and maybe just a preliminary way to meet up and uh, put this forward, how this will work out in Indonesia. Now, let me now move on to what I also want to share as I was required or requested to present on what healthcare without harm is doing across the region in terms of climate resilient and sustainable health system. In the larger picture, what I see now as the significance of the paper on Indonesia's health adaptation measures vis-a-vis climate that can be pursued. The big picture that we see is the strategic opportunity to build on the overarching effort to align the health sector with the ambition of the Paris Agreement by aligning it with different group of countries. Our own ASEAN, the G20, who just had a meeting in Indonesia a month ago, and we heard that India, another big country in the Asia region, will host the next G20, and there is so much attention that will be onto climate and health. So we want to see alignment of the healthcare as a sector globally, also as a sector at the national and regional level, aligning itself with the ambition of the Paris Agreement by working with different policymakers at the country level. And we have the COP26 outcomes for us to stand on. and move forward. The COP26 was the one held last year. The last one in Egypt is the COP 27. Now, and as we work along with countries as a healthcare sector, therefore we need to work with our ministries of health. But to work with the ministries of health, we need to showcase hospitals doing it, both at the national level or even at the local level, healthcare facilities. And we need to mobilize and have the voice of the healthcare sector articulated on climate issues. So let me go over quickly to some of the slides that I prepared, but I think I'll pass through many of the slides because of the time, and I would really want us to have a substantive discussion. Now, apart from one of the, or the, what is considered as the biggest cyclone in the world, visited the Philippines in 2013, that was Haiyan. Now, last year, what is considered as the second strongest is the Typhoon Rai, again experienced in the Philippines. And every time, it's not only agriculture, it's not only communities that are destroyed, impacted as well are health facilities. And this is the case of Haiyan in 2013. So if we, even as we study impact on diseases because of climate events, we also need to see impact of climate change itself to the readiness and resilience itself of hospitals. And that is one piece that I think a bit missing in the study. Maybe it's a deliberate thing, but I can imagine it will be more complete if we also go thoroughly on how to prepare the healthcare system as a infrastructure, as a building, as a healthcare system in itself, because of the increasing ferocity and frequency of climate events, be it a flooding, typhoon, or even drought, severe drought. Now, in the study made by Healthcare Without Harm in 2019, this is the if we measure, or if we consider the healthcare sector as a country in itself, then the healthcare sector will be the fifth largest country in terms of emission, equivalent to 4.4 of global net emission. So on one hand, we can talk about impact on diseases, but we should also address our own share, our own sense of responsibility on why is climate acting up in the way it happens, and how do we contribute. Now, Indonesia, Philippines, and small Southeast Asian countries are not as guilty. Unlike, for example, you take the case of Japan, of China, of India now, and of course, the larger industrial Western countries who are responsible for a large portion of the emission that make us suffer in our own region. And yet, we still need to take that into account. And addressing resilience, therefore, and building adaptation measures should also mean reduction in terms of greenhouse gas emission that we utilize daily in operationalizing our hospitals, in treating our own people, in building and running hospital as an infrastructure. I'll skip some slides, but just to share, we are running a research in Healthcare Without Harm Southeast Asia, the one I'm managing, on what is the level of understanding and work being done on adaptation and resilience in healthcare. We're comparing ourselves with other regions, South as in Africa, in Latin America, and the perspective even of our colleagues, the global green and healthy hospital members in the US or in the Europe. The and the finding so far is that there is a clear consensus that healthcare operations, especially the high use from hospitals, contribute significantly to greenhouse emissions. If that is not understood yet among our colleagues in healthcare, then we have a role to play to explain it fully. But that consensus is growing and becoming acceptable. Climate change may perpetuate health inequities, especially socially and economically. This is another thing that is not fully developed in understanding resilience in healthcare. That we are building resilience, we are building uh, uh, hospital buildings, infrastructure that are meant to meet the challenges of adverse climate events, but not simply because we want them to remain standing, but rather we want to address the health inequity and the lack of health access among people, particularly those in the margin. And again, this is very true in Southeast Asia. However, as we are studying further, such resilience framework do not necessarily address the equity or even the burden of disease being carried by the poor, resulting from climate change. Focus of framework and assessment tools, therefore, should shift from disaster preparedness and simple emission counting to addressing uh, preparedness in terms of resilience and adaptive capacity of hospitals, but promoting equity in terms of health access. And this is why, for example, renewable energy, putting solar panels across the roof of hospitals is an equitable adaptive measure, especially if you put it in places where there is no regular access to electricity, because it makes energy equitably accessible to hospitals that can therefore serve more people in those communities that has no access to energy or to electricity. Now, knowledge among the healthcare workforce, both in disaster preparedness and the health impacts of climate change, is lacking. This is very true even among our own members in the Global Green and Healthy Hospitals Network. There's a lot of education, a lot of training, and persistent discussion, whether it is on impacting on waste, on your own lifestyle as a healthcare worker, on the transportation mode being used inside the hospitals, in the way air conditioning is set in every room in the healthcare facility. There should be a deliberate discussion on where we are able to build resilience, mitigate the carbon emission, and therefore be more adaptive. While there is a growing evidence and research on the impact of climate change on health, there is a lack of research to test the effectiveness of healthcare interventions. I want to reflect this to the first presentation. The research and the evidence and even the second presentation is there, but how much does it translate to an effective healthcare intervention? There is nothing that shows that link. Lacking are indices and metrics which qualify cost reduction and carbon reduction in investing in sustainable healthcare infrastructure. And there is a need to evaluate whether the frameworks are having a significant impact on resilience as a whole, which make it unclear which adaptation and mitigation strategies are the most effective. So this is the stage where we are at the moment. We have studies, we have models, we have policy proposals, but which ones really work? Especially in the context of Indonesia and the Southeast Asia as a whole. So that's where research, I think, should also be focused on. Now, the other thing that we should consider, the literature on climate and health, on adaptation and resilience. There are not too many, but they are mostly were there prior to the pandemic. And the minority that were published after since the pandemic address the future phenomenon for healthcare, dual disasters, or multi-hazard burdens. However, what we learned from the pandemic is not yet inputted into the study on resilience and adaptation in healthcare settings vis-a-vis the threat of climate change. So I think I'll stop at that. There's more I want to show colleagues, but I'll pause at that anyway. I led my presentation, and that can be reviewed. That you can ask more questions, and so we can. I hope we can have more discussion. Thank you so much. All right, I'll stop sharing my screen. Oh, it's already stopped. Shall we proceed with the question and answer?
Okay, thanks, Mon. Let's have the reaction first from Dr. Ferdinand. A reaction to the reactions.
Thank you, moderator, yeah, Mr. Randolph. Thank you very much, Prof. Budi, Mr. Raymond. I think most of is to enrich the study and how we interpret the study for a betterment of the society, how we use it. So from Professor Budi, I think much more research on specific disease. Indeed, we still need it because we have to think about two parts: environmental health, where we are living, and human health, how it's affected to human. So this is two different objects in my view. You might live in very healthy environment, but you will get sick because of your body, etc., etc. And specific disease, they will have specific characteristic, etc. So we need to understand it. But we also need to get the generic essence of the environmental health, how the environment is healthy, what kind of indicator for the environment we say is healthy before we are going too deep on its specific disease. And I think research on these things, like Professor Budi suggested, including specific data, socioeconomic, etc., the variation across Southeast Asia, like Mr. Ramon says, would be very interesting. So the main issue is how we can have a good database on this one. So because when we only do research country by country without having structuring the data set, the standardized and everything, then everything can be just gone after the project is ended. The second one, all comment of Mr. Ramon, I take as a note here. The essence is actually two things. The first one is the benefit of adaptation measures. As we already says, the cost of the climate change is quite huge. So if we do adaptation, how much benefit we can get? And if we are doing late, how much further cost? This is very, very important question, and it's not easy to answer. Yeah, the study that I did with under guidance of Mr. Banzon is just 1 or 2 months, if I'm not mistaken. Yeah, Mr. Ramon. So we just do really mapping what's going on. So if we can do this, what's going on in the country across ASEAN as our policy paper to the presidency, ASEAN presidency next year in 2023, it will be a good input. And then you also say connecting with G20, etc. That's huge. So just do this mapping like we did in Indonesia across Southeast Asia. We can see the generic finding and the generic gaps. So we can tackle those things for the region. And then the second one, when you say about the resilience, so this is always a critical question, yeah. Very easy to ask, but very hard to answer. Because resilience means we are adapting to the new situation and we build better than before, because there is the critical point of transformation. And I think Mr. Ramon provide a very excellent suggestion. What can be done? All modalities are there. We already have the policies, we already have the tools, we already have the program, etc. So what we can done? So just example of Indonesia, it seems everything is already in place, Mr. Ramon. But when we look at one by one, going to further detail, actually much more is needed. For example, the healthy climate villages that we propose to the Indonesian government. They call it Desa Desi. In Indonesia, we say Desa Sehat Iklim, translated climate healthy village. So this is still not implemented yet. So this is just initiative of the Indonesian government to put in place how the community can participate in climate change action. So when the community participate in climate change action, we have to distinguish into two big groups. The first one is autonomous, that the community can do it by themselves. The second one is by design, or I can say systematic approach. What kind of strategy, program, etc. that can be used to equip the community in order to addressing climate change impact in the country. And you tackle down a very important issue when we are saying about climate resilient pathway. Across the healthcare sector, there are people, healthcare practitioners, and then there are facilities, our hospital, etc., etc. How this also climate resilience in accordance to the new theoretical background of climate resilience, that is not only talking about the adaptation part, but also talking about the low carbon emission. So you say there are a lot of modalities like carbon footprint, etc., that you name it before. I think this is what I mean. We map it in Indonesia during this study, this 2-month study. We map it, all the modalities that is already in Indonesia, including the tools. If we can have it for the Philippines, if we can have it for the other countries, and then we can have like a similar tool or a very dedicated tools that can be used across country in the Southeast Asia, that will be great, because we can reduce the cost of adaptation for this one. And then we also can encourage much more implementation in a number of countries. Just to give an examples, when you say, for example, the local adaptation action, what kind of tools that can help the local adaptation action? I'm thinking to create, Mr. Ramon, like a calculator, just very simple calculator. So we can use it like the Google Map, for example. The Google Map, you just put the address, they will find for you where is the direction, etc. If we can have a tool like this for our health risk assessment or our health risk environment, or maybe we can go further, health risk to human, because environment and human, to me, this is two different objects. If we can have this kind of things, so when people turn on their mobile phone, we can take the geolocation and we can tell them what kind of potential disease that occur surrounding their environment and what kind of action they can do. And then we can provide the direction, the nearest healthcare facilities if something happens. And then maybe the tools can also be used for disabled people. They can provide sound, voice, or other thing. I'm pretty sure this is very easy to speak, yeah, Mr. Ramon, but huge effort is needed. And I don't think 1 or 2 people can do it this one. Maybe we need across countries, across the region to work on this thing. As now, I'm also one of director at Siamia Biotrop. Siamia Biotrop is organized focusing on tropical biology for the 11 countries. Maybe we can have this kind of hub like next week. I will have some discussion, Mr. Ramos and Mr. Benzon, about the potential of having collaboration with the 24 universities across Southeast across Asia. So this thing, the important thing what I imagine is how we map the modalities, how we share this one. indeed, we need some resources, yeah, Mr. Raymond, because we need people to do this thing, and they also need some salary, they need some honoraria, something like that. Yeah, we need to acknowledge all the required resources. But like you said, we also need to measure the benefit of doing so, because late adaptation or late mitigation may burdensome in the future for the country development plan and etc. So we just need also to formulate and package these very complicated issues, including even my report or maybe Pak Budi or your report, to decision makers. So what is the specific things that they need to know? No more than one page, for example, because they might not have much time, yeah, to read much more than 2 or 3 pages. So how we can have this thing elaborate in very precise information, but very easy to digest for the policymaker. Like you says, connecting with the ASEAN, G20, etc., is a huge impact, particularly when we are talking from the ADB perspective, because ADB, World Bank, and others, I'm pretty sure you guys also working under a couple of financial mechanism. Just to let you know, I am now involved a bit with the Green Climate Fund, Green Environmental Fund, and a couple of international fund setting, including the new establishment of funding system in Indonesia. So that's what I'm saying. Maybe in the next opportunity, we need to invite from the Ministry of Finance, Ministry of Development Planning, Ministry of Environment, because health sector is prioritized. By saying prioritize means there is other agencies, other institutions, they might have some issues connecting with us. Just to close my explanation, last week I was invited by Ministry of Public Works. They are talking about irrigation canals and dam, how they can provide a better services for the irrigation canal and dams. So this is, they try to link with climate change, because the water supply might dictate how they can manage the dam, the irrigation canal in the future. And if we look at the link with water sector, like Pak Budi explained, maybe vector-borne disease, etc., also need much more attention. So this complicated connection, we need to simplify, yeah, Mr. Raymond, and then we can, by using your word, what we can do then. The policy is there. The tools, maybe we need to improve. The community action may some in other areas, but how we escalate this kind of action across the country in order to the betterment of the society, in order to mitigate the risks of climate change on health sector, and providing a better environment, healthy environment, and increasing our human health system. So the resilience is there for mitigation and adaptation. And now it's time to collaborate. And how to collaborate, maybe we need to formulate, because everybody cannot do everything what Pak Budi can do at his expertise, Mr. Raymond in your the Philippines. I frequently went to Siarka actually, Mr. Raymond. So before COVID-19, yeah, after COVID-19, just stay in Indonesia. Maybe that's my reaction. This is really nice and fruitful discussion, I think. Thank you.
Thank you so much, Dr. Ferdinand. I would like to ask the body if there are questions that they want to raise, or suggestions, recommendations. Actually, this webinar is very interesting. There would also be other webinars in the future, as a result of the discussion on climate change and health.
Yeah, if we
So-
can change the title, yeah, Mr. Randolph, strengthening health system resilience against climate change in Southeast Asia.
In Southeast
Because,
Asia, yeah.
because I know ADB actually already have a report on climate impact across Southeast Asia in 2009. So that's every time I calculate the estimated cost, Mr. Raymond, usually I validate with a number of report from ADB, World Bank, and other international institutions. So we can have like the figure supposed to be within the range. So ADB already did in 2009, right? So ADB can do it again for the next 2 years, yeah, Mr. Randolph.
Okay, so if there are none, can we call on if Dodo's still here? Doc Dodo,
Yeah,
close.
I'm here, Randy, and probably allow me to thank Ferdinand and the team, Dr. Budi and Mon. I think we probably need more time, probably sitting face to face across each other to have to continue this discussion that we have on climate change and health. I think what's important is that as we listen to the work that's been done by Ferdinand and his team, Dr. Budi, the insights of Dr. Budi with a focus on environmental, epi, and the infectious diseases, the broad systems thinking perspective that we hear from on. There's really a lot of more work that we need to do on health and climate change. I think what's important for us to see is that this is now really something we talk about. And as I've said, and as everyone knows, we in ADB expects and we will be supporting more work on this. We're hearing a lot of recommendations from the tool that was the calculator that was proposed by Ferdinand. We are also, of course, working with Healthcare Without Harm to see how the work that they've done can also be done much more broadly. We also hear Dr. Budi's, in a sense, point that we should do more time series studies, where some of this is really work that's outside the ambit of ADB. But I think we all know that all of these are necessary for us to have a better understanding on how we should be able to mitigate the impact of climate change on health and how to ensure that we harness the health sector as a climate change adaptation tool. So allow me to thank again Ferdinand, Ikrom, Raiko, and the rest of the team. I would like me to thank also Dr. Budi and Mon. And as I said, we hope to have more conversations in the coming days, weeks, and months. So, Randy, everyone, thank you for coming.
Thank you, terima kasih.
Thank you.
Bye.
Terima kasih
Bye-bye.
semua.
Terima kasih.
Prof. Budi, makasih banyak.
Prof. Budi, terima
Mr.
kasih
Raymond, thank you
banyak.
very much.
Mas Raymond.
Hopefully we can work together
Oke,
ya.
sama-sama.
In the future ya.
Yeah.
Because
Ya,
this is just
sukses.
mapping the modalities. Thank you.
Thank you, Pak
Bye-bye.
Dodo.
See you, Pak Dodo. Thank you very much.
Bye-bye.
At the end of January. So let's
Yeah,
talk.
we are really hoping to have you in Jakarta, ya, Mr.
No, I will be going to Jakarta then.
Or I and Prof. Budi
You
can go to Manila.
Yeah, and that we can arrange as well. Okay. Bye, everyone.
Thank you very
Great
much,
idea.
Mr. Ramon. Bye-bye.
Bye-bye.
See you, ya.
Bye.
Thank you.